This is chapter 12, continuing our discussion on how to treat the different types of shock. We've talked about cardiogenic, and now we'll move on to obstructive shock. It kind of depends on what's causing the obstruction as to how you're going to treat it. For cardiac tamponade, your main priority is going to be increasing cardiac output. So it's hard to do that in the field. What we want to do is apply high flow oxygen to maximize the oxygen that they are being able to push around. Surgery really is the only definitive treatment. There's a procedure called a pericardiocentesis, where you actually take a needle, generally under ultrasound guide, and put it into the pericardial sac and withdraw that accumulated blood. There are some very, very advanced, like critical care services that allow this to be performed in the field, but the risk of infection is so high. I've seen it done a couple of times within the ER, and even then they're a little nervous about it. But even if you get that blood out of there, it's a temporary fix because you have to fix the underlying problem, what's causing that blood to get into that space between the pericardial sac and the heart itself. For tension pneumothorax, you're going to apply a high flow oxygen to prevent hypoxia, just like you would with anything else. Usually the only action that can actually prevent death from a tension pneumo is decompression of the injured side, so relieving that pressure to allowing the heart and the lung to fully expand again. The best way to do this is going to be within the hospital, actually putting a chest tube in. ALS does have a skill that they can do called the needle chest decompression, where they actually take a large bore needle and put it through the chest wall to relieve some of that pressure. It's not going to fix the problem. It's a Band-Aid, but at least can relieve some of that pressure so it's not pushing as far onto the heart and onto the other lung. If you can get ALS there relatively soon to have that performed, you'll definitely be a little bit better off, but needle decompression is still just a Band-Aid. They need to get to the hospital. Septic shock, they have to go to the hospital. Bottom line, they are going to require ungodly amounts of fluid. They're going to require antibiotics. I mean, truly, their care is going to be extremely complex. There is not a whole heck of a lot that we're going to do in the field for them, unfortunately. You want to make sure that you protect yourself from whatever is causing them to be septic. So make sure that you use your standard precautions so that you don't fall victim to whatever is causing them to be so sick. High flow O2, ventilatory support may be necessary if they don't have adequate tidal volume. If what's causing their problem is pulmonary in nature, is within their lungs, they aren't going to be able to be ventilating themselves appropriately, so they might need help from you. You want to use blankets to conserve body heat. Even if they have a fever, we're not packing them with heated blankets and whatnot, but trying to keep some of their body heat in will be helpful to them. Oftentimes we kick up the heater in the back of the rig. You'll probably be uncomfortable because our clothes are just crazy hot, but it's comfortable for your patient, and we're taking care of the patient before we take care of ourselves in that aspect. You may have to notify the hospital prior to your arrival because they may have a sepsis team, much like they have a stroke team, much like they have a trauma team. They're starting to have these sepsis teams also because they're finding that they're not treating patients with sepsis effectively enough. And so we're trying to help with positive patient outcomes. They're transitioning to this. So if your system has a sepsis alert, make sure you activate that as quickly as possible. Neurogenic shock, often we're not going to be able to do a whole lot for them, unfortunately. Because it's a spinal cord injury, most of what we'll do in the field is just going to be supportive care. Typically, we're going to have to obtain and maintain an open airway, spinal immobilization, have to provide ventilation support for them. Oftentimes, a high spinal cord injury, that's right where your respiratory control centers are. So they may not have those signals going to their body saying, hey, you need to breathe. So we might actually have to assist them or take over breathing for them. Conserve their body heat, ensure the most effective circulation possible, which kind of depends on what you can do. As a BLS provider, you don't have the meds to really help that much. So ALS providers getting on scene for this is going to be helpful. And then transport as promptly as possible to a facility that can manage spinal injuries. Around here, we really don't have many options. We've got 2 hospitals, and you're going to one of the 2 of them. There's not a level 1 trauma center here in the city of Sioux Falls, or actually even in the state of South Dakota. Fargo recently got level 1 distinctions, but we are a level 2 center here in Sioux Falls. Treating anaphylactic shock. Really the only effective treatment for a super severe allergic reaction is to administer epi. You guys have to do it via either IM or auto injector, but that's going to be your frontline treatment. Epi, 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 because it's actually going to stop the reaction from progressing. So epi is your frontline treatment. Then next we're going to go with high flow oxygen to help with that ventilatory support. But if we just start pouring oxygen into them without stopping the reaction or starting to reverse it with epi, it's not going anywhere. It's not going to be able to get into the body. So focus on epi first, high flow oxygen. And of course, there's 2 of you typically on a rig. So one of you is focusing on getting the oxygen set up. The other one's administering epi to the patient. I mean, this is not a, you have to do A, then you do B. I mean, use a little bit of common sense with that as far as prioritizing what you need to do for your patient. If that patient knows of this severe allergy, they may have their own medication. So you may end up just having to help them administer their own. Make sure that you go ahead and ask them, double check your rights of medication administration, and follow through with that. You may want to spend a little bit of time finding out what agent caused the reaction and how they actually came in contact with it, just because you might keep this from happening in the future. But if you can't identify that, you're not staying on scene looking for a bee or looking for a piece of food. Just transport and they'll figure it out after that. We talked about already that it can start out pretty mild and then your patient can go downhill very, very, very quickly. So make sure that you're reassessing your patient sufficiently. Psychogenic shock, if it's uncomplicated, generally fainting is like the brain's way of hitting the reset button, or, you know, when your computer's acting up and you just smack it a couple times. That's kind of what your body is doing in psychogenic shock. Once you smack the floor, then everything kind of returns to normal and they tend to do fine after that. However, if it's complicated by a different type of shock, then those 2 might compound on each other and make the patient worse off than what you would think that they were. We do always want to be careful with patients that have had a bout of psychogenic shock, just because oftentimes they fall. So we need to check for injuries, especially to the head. They tend to lead with their head when they go down, unfortunately. Especially in those older patients, we need to be cognizant that even just a fall from a standing height could cause some pretty severe injuries. If the patient says that they can't walk, they're feeling particularly weak, you suspect more of a problem than just, oh, he stood up too fast and he fainted, go ahead and transport. It's always better to be on the cautious side than to say, no, they're fine. It's fine. Again, you'll start getting that feeling in the pit of your stomach of something's not right here. If you get that, don't ignore it. The protocol says that any patients that have had a loss of consciousness should be transported for evaluation. However, if they are A&O times 4, they are absolutely within their rights to refuse transport and to refuse care. So make sure you document. Hypovolemic shock. First and foremost, control the bleeding. Make sure that you're not continuing to lose volume. So start with direct pressure. If you can't control with direct pressure, consider using a tourniquet if it's on an appropriate part of the body. Obviously, we're not putting a tourniquet around the neck. Believe me, I've seen it. Not from a healthcare provider. Somebody else put a tourniquet around a person's neck, but no. So try and control as best as you can. Handle the patient relatively gently and continue to keep them warm. Again, lots of physiologic concepts that go into this, but just know that that really actually does make a difference. If they have internal bleeding, aggressive support, a lot of that's just going to be keeping them in a position of comfort, giving them high flow O2, and transporting rapidly as possible. Even an ALS provider can't do a whole lot for internal bleeding. Yeah, we can give them fluids, but if they're losing enough blood, even giving them fluids isn't going to do anything because we're taking out their ability to clot. So their blood doesn't actually form a clot as efficiently. They're trying to clot with Kool-Aid because it's so watery. So not a whole lot that we're going to do there. You want to make sure that they don't end up vomiting. Those that go into shock tend to get pretty nauseous. Respiratory insufficiency. You want to secure the airway as quickly as possible. Continue to clear the mouth and throat of obstructions, mucus, vomitus, etc. If necessarily, you need to provide assisted ventilation with a BVM. Always have that attached to oxygen and transport quickly. Shock in older patients. Older patients tend to present more complications. They have the aging process that has already started where they're not compensating as well. And then you add that onto the numerous medications that they're on and their chronic health conditions that could make their body unable to compensate like you would expect them to. There's so many different physiologic changes that go on as you age that makes them not so fun to take care of when they have a serious illness or injury. It also makes them more susceptible to complications. But as with anything else, these are concepts to keep in the back of your mind. We're really not treating a geriatric patient any different from a pediatric patient, any different from a middle-aged patient. The guidelines are the same. Overall, providing spinal immobilization, controlling life-threatening hemorrhage, suction if needed, providing high flow O2, however you need to be adequate for your patient, maintain body temperature, and provide rapid transport. That's all the general basis for taking care of anybody that's in shock. You just need to know that there's more affecting how these treatments are going to make changes within your patient or what their general trend is going to be. So certainly keep that in mind. This is it for chapter 12.